David Frank. I'm a cancer specialist at the Winship Cancer Institute, and I'm delighted to be with you here tonight. I was drawn to the field of oncology for two main reasons. First, I wanted to take care of people who had serious illnesses, who were dealing with life-threatening situations, where I could hopefully make an impact on them in terms of their outcome and how they proceeded with their life, that I could have a meaningful longitudinal relationship with the patient and their loved ones. The second reason I was drawn to oncology is that from very early on in my career, I realized that scientific research done at the lab bench, could provide insight into the basic mechanisms of a disease like cancer and could provide the opportunity to develop new therapies that could completely change the outcome for patients. So as you heard, I became a physician scientist. I take care of patients with leukemia and other blood cancers, and I run a laboratory. And both of those together, to me, are what the future of oncology is about, and I'd like to take a moment to talk about each of them, first talking about the laboratory. So I was interested in cancer research going back to when I was in college at MIT. And MIT was very transformative to me because there was a great emphasis on basic mechanistic research, but there was an equal emphasis on developing practical solutions to real-world problems. And that is how I got into the field of cancer research. And actually, the word tumor is from Latin, and it means swelling. And even in antiquity, it was recognized that when people had a mass, lumps and bumps where they shouldn't, that could easily become a life-threatening situation. And we used to think that a tumor was a solid mass of malignant cells. But it's actually somewhat different, and as we've developed single-cell techniques, the ability to dissect tumors down to individual cells, we really see, to use the term that Dean Wong used, it's an ecosystem. It's a malevolent ecosystem, but it's an ecosystem. There are the malignant cells, but there are also other quote-unquote normal cell types as well. There are nerve cells, there are contractile cells, there are blood vessel cells, there are fat cells, there are immune cells, and it's a very dynamic equilibrium. And all of these cells in this ecosystem are actually interacting with each other and sending signals both from their direct contact as well as by chemicals or hormones they release that leads to the continued growth of a tumor. It's driven by the malignant cell, but all of these other cells are participating, and it actually leads to the ultimate growth and spread, which can become life-threatening. So one of the things that my laboratory has focused on is understanding that signaling, the communication among cells in a tumor mass, and what is driving the malignant cells to continue to grow and expand and to become a life-threatening tumor. And it's actually interesting that there are certain tumor types, like Hodgkin lymphoma, in which only a minority of the cells within a tumor are the malignant cells. Most of the cells are these normal cells that have been recruited by the malignant cells, but the net effect is an aggressive tumor. And so from laboratory studies in which we understand this signal that occurs between these cells, we've been able to identify drugs to block those signals. And then, as you heard from the introductory remarks and from Dean Wong's comments, the next step was to do clinical trials. And right now at the Winship Cancer Institute, drugs that we've identified in our laboratory are in clinical trials in advanced ovarian cancer, in development for certain forms of lymphoma, certain forms of brain cancer. Very difficult to treat tumors, but it was exactly what Dr. Wong was talking about, going from basic observations in the lab, going into clinical trials, trying to help patients, trying to give that extended life that you heard about earlier. And I think that is something that the Winship Cancer Institute does in a beautiful way. I see patients on the second floor. My laboratory is on the fourth floor. We have samples going back and forth. And again, there's using knowledge and using talented individuals to study cancer. We are developing new therapies being tested in people that I'm confident will make a difference in the outcome for patients. So as you heard, I'm a physician scientist. I also do see patients, and tomorrow morning, Wednesday morning at 8 a.m., I'll be in clinic They're on the second floor seeing patients with leukemia. And being in a teaching institution as prominent as Emory, and again, Dean Wong talked about this, when I see patients, I almost always see patients with a student, often a medical student, sometimes an Emory undergraduate student who's going to be going into a career in medicine. I'm also usually accompanied by a fellow. This is a physician trained in internal medicine who is now doing subspecialty training in hematology and oncology. And so before we go see a patient, we talk about all of the molecular things that I just mentioned. We talk about the mutations in the specific genes, how we're going to target that in a patient. However, as I always try to teach the trainees with me, if that's all we're doing, we're not really delivering to the patient what we should be. So a very famous physician who lived over 100 years ago, Sir William Osler, said, "A good physician treats the disease. A great physician treats the human being who has the disease." That's what we're trying to do at the Winship Cancer Institute. That is what I'm trying to teach to the trainees who are with me. Yes, we need to know the molecular abnormalities. We need to target that, but we need to know the human being that we're sitting in the room with. We heard about artificial intelligence. There's no question that that will transform a lot of what we do. But artificial intelligence is not going to take the place of holding the hand of a person who's dealing with a very difficult situation or providing comfort in those times of difficulty for our patients. And in the last few days, I can give you a couple of examples of this. I saw one patient with my fellow last week who told us how her daughter is getting married next month in November. And what she said was she wanted to be able to dance at her daughter's wedding. And yes, we're going to continue to treat her leukemia, but whatever we can do to make her feel good for that day and have her be able to participate and enjoy that event. We saw another patient, a man who told us that for years, he and his wife, for their 50th wedding anniversary, were planning to take a safari to Africa. And he wanted to discuss how I would continue to monitor his leukemia when he was 5,000 miles away, to allow him to participate on this trip that he had promised his wife they were going to go on for years. And also to make sure that whatever I gave him wouldn't interfere with the medications he needed to take to prevent malaria while he was on the safari. And that was part of what we do too. And I'll give you one final example. One of the patients we were going to see was a patient I had treated for acute lymphoblastic leukemia, ALL, a very aggressive leukemia in adults. And the treatment for this entailed very intensive chemotherapy, most of which was given in the hospital. And then after that period of time, there were 24 months of what we call maintenance chemotherapy. The patient would come in, get an IV infusion, would take oral chemotherapy, 24 cycles of this over 2 years. And last week, we were seeing this patient. It was his 24th cycle, his last cycle he was coming in for. And the fellow said to me before we went to see him, "Wow, I bet he's going to be thrilled that, this is the 24th and final cycle of his maintenance." And I said, "Okay, why don't you go in and see him and talk to him and then come back and then we'll see him together and let's find out." And a few minutes later, she came back and she said, "Well, he is thrilled that he's finishing his chemotherapy, but he is also petrified that he's finishing his chemotherapy. And he's petrified that he's not going to be coming in every month and seeing the nurse and the doctor and everyone on that regular schedule. And if there's anything bothering him, he can quickly ask, and that he's going to have to be out on his own a little bit." And I tell you these stories just to give you an idea. I can tell you all of the mutations in these people's cancer cells, but that isn't the only thing. These are human beings who are going through life, and our job is to take good care of this human being. I think that the goal that we try to bring is to deliver the best cancer care, to do groundbreaking research, to understand the molecular abnormalities in the tumor cell, to bring forth clinical trials based on a rational understanding of cancer. But it all has to be in the context of taking care of people. That's what we do. We take care of people. And I think the Winship Cancer Institute does an outstanding job in providing that patient-centered care. As we were discussing earlier, this is not just a theme, it's a way we actually take care of patients. And so to me, groundbreaking research, focusing on the molecular abnormalities in the cancer cell, bringing them to patients in a clinical trial, and taking care of human beings in a kind, considerate, and compassionate way. These are the essences of what we do. These are the essences of what we need to do. I believe we do those incredibly well at the Winship Cancer Institute. And the two of them together, scientific advance and the care of the individual patient, that to me is the future of oncology. Thank you very much.